Hello, everyone, and welcome to the Body Wisdom Podcast, where we discuss the mind-body connection and its relationship to health and well-being. My name is Tami Bulmash, and today's lovely guest is Candace Cox, who will be joining us all the way from Ontario, Canada. Candace Cox is a theater professional and writer. She has been an Alexander Technique teacher since 1997 and is certified by both the Society of Teachers of the Alexander Technique and Alexander Technique International. She has combined her love of stage and Alexander Technique to work as a movement specialist, course instructor, and Alexander Technique coach for many years with organizations including the Stratford Festival of Canada, Globe Theatre, Opera Nuova, the University of Alberta, and the University of Toronto. She also maintains a large private practice in both Ontario and Alberta. In 2019, Candace completed a book about her work with the Alexander Technique and Parkinson'S, Living Daily, Alexander Technique for Parkinson's Disease. Her passion for applying Alexander Technique to Parkinson's disease continues to grow. Postgraduate teacher training combined with traveling to work with Parkinson's communities around the world is next in her sights. A program like this could also be the basis for a large-scale clinical trial, which is her ultimate goal. Candace lives with her family on a small hobby farm in Eastern Ontario, Canada. She is currently working on a novel about Parkinson's disease and the Alexander Technique. Hi, Candace, and welcome to our show.
Hi.
So Candace, I am so happy to have you here today, and I am really interested in the book that you've written. It's really remarkable to me how your path with the Alexander Technique and your background with theater led you to writing the book that we're going to discuss today, Living Daily, Alexander Technique for Parkinson's. But before we get started, could you please share, just so that everyone is familiar with the term Parkinson's disease, what is it exactly?
Well, Parkinson's disease is actually one of the most prevalent neurological disorders in the world, second only to Alzheimer's disease, I believe. There's 1 million people in the US with it, 10 million internationally. And it's a horrible disease. So it's a progressive degenerative condition, which means that it progresses, it gets worse, and it's degenerative. So it's breaking things down as it goes, and there's no cure. So when we are talking about working with Alexander Technique and people who have Parkinson's disease, we're approaching the work as what's called an adjunct therapy, which means in no way am I saying that you would use Alexander Technique instead of medication. But medication also is only at this, where we're at right now, medication is only able to mask symptoms. So everything with Parkinson's is about symptom management. Even surgery, deep brain surgery, is about managing symptoms. It's not about curing the disease. I mean, I don't want to get too technical, but essentially what happens is the dopamine receptors in the brain, which carry information to your whole system about what you're intending to do, they disappear. And so it reaches a point when you have so few dopamine receptors that messages just stop going through your system. And that means that it affects every patient in a different kind of way. So when we use Alexander Technique, we're giving students the power to manage their symptoms in a different way.
Wow.
And that's really, again, you could talk about, no one knows exactly what Parkinson's is to this day. But I've been privileged to attend 3 world congresses now on Parkinson's disease. And it's evolving, but it's like that ball in the pond. It's just slightly out of grasp. So we continue to mitigate symptoms, and that's an important thing to do.
Yeah. Well, your book you wrote is incredible. I think it's really something that every Alexander Technique teacher should have at their disposal, because it's wonderful to be able to see how to apply the Alexander Technique to people with PD being Parkinson's disease. And your book opens with a story that brought me to tears. It was told by Blanche, who is the wife of Phil, who is one of your students. And he was diagnosed with Parkinson's 9 years before he began taking Alexander Technique lessons, and he was 72. years old and had taken 28 private Alexander Technique lessons. And he also participated in group lessons. And his wife, Blanche, describes him as a man who lost his smile to Parkinson's, that he lost his joy and confidence in himself. And then she goes on to describe the loss he experienced, like his ability to tie his own shoes or get dressed on his own. And she described how she had to resign from her job and become his full-time caretaker. Mm-hmm. And so then Phil became part of a pilot study to see if the Alexander Technique could make a difference for people with Parkinson's. And after the first lesson, Blanche said that she could see how much Phil changed, that he had a ton of anxiety lifted off of him, that he had joy now, and that he had a future. And for people who aren't familiar with the Alexander Technique, they might be wondering, well, what happened in that lesson? What was different for Phil? And so could you explain part of the process you experienced working with Phil and what that was like?
Yes. I mean, it's a big topic because Parkinson's symptoms present so broadly. So in the case of Phil, he was pretty, in a typical progression of rigidity, which meant that basically his joints just locked up. And that's unfortunately a pretty common thing, especially particularly for men, I would say, in my experience of Parkinson's. But we know that exercise helps people who have Parkinson's. But Phil and Blanche were trying, they were doing everything they could. She'd quit her job. But when I met them, the first day that I met them was in the lobby of the Parkinson's Association where I was teaching. And I happened to just see them out of the corner of my eye. And so Blanche is 5 feet tall. And Phil was 6'6" or 6'7", a big man.
Wow.
And they were trying to get him to stand up. And it actually made me weep watching because he couldn't bend. So he couldn't get out of the chair. And so there's this little woman bracing, to kind of rocking him back and forth. And Phil had progressed. Again, I want to apologize. If there are people who have Parkinson's disease who are listening to this, I want you to not get discouraged as we talk about where people are, because what I do love about this work is there are things we can do, which I love. But Phil had progressed to a point that he was headed for a wheelchair. Absolutely. And remember that this is a progressive degenerative disorder. So there is nothing that we know of right now that turns it around. Nothing. I shouldn't say that. Medication, when people are first medicated, they'll have some remittance, but then it just increases and increases and increases. It's a hopeless kind of thing. But in Phil and Blanche's case, we had to start working on getting him movable, getting his big movement joints actually working so that he could bend. And so that's where we started. And he was incredibly strong. So the first lesson, I worked with him in a typical Alexander way. I lay him down what we would call semi-supine in the technique and really worked with range of motion. So it's almost like from the outside with Alexander technique, we're able to show someone's body where it can go because the pathway's been lost. It's like we're restoring function from the outside in. So just exploring that range of motion and showing them where it can go. Now, there was no instant miracle from where I was sitting, but from where they were sitting, the miraculous thing was that they had hope. And so on we went. And then by the end of that week, of course, Phil had progressed so much that the crowd of people who were around doing the testing and the staff of the center all came to watch Phil's final test. In the first test, he fell over onto the testers because he locked up and fell backwards, this huge man. Wow. So that was exciting. They caught him, but everyone was a little stressed and a little nervous. So when we retested on Friday, the whole building just erupted with cheers. It was amazing.
Wow. That's wonderful. I just think that story, I mean, it just brought me to tears because you just think about what someone who is newly diagnosed is going through and how isolating it can be for them. And they trust medication, the medications don't work. And then they are like, you know, what is this thing going to do to help me? And then when it actually helps them and it gives them hope and it restores faith, it's, I mean, it's just incredible, really incredible. And that you got to experience this and facilitate this progress for Phil. And I wanted to also ask you, Candace, why were you particularly drawn to working with people who have Parkinson's?
Well, I mean, it's interesting. My background is as a performer. But in 2003, my mom was diagnosed with terminal cancer. So that was the first time that I was challenged to look at using my skill set to help my mom in any way that I could. And you know, mom was such a trooper. She talked about how much difference it made. Now, I was, of course, looking for a cure, which didn't happen. But I realized in retrospect that it's a lovely thing in that case, just to be able to give someone ease wherever they are. So I'd worked with my mom, and then immediately after she passed, like within a week of her funeral, someone came to my studio who had scleroderma, which is another horrific disorder. And we started to work, and it made, you could say, miraculous differences in her. So much of it is, it's about the patient who becomes the student. It's their work, not my work. Like, I'm not a miracle worker. I'm a guide on a journey to a different way of thinking and a different way of being able to choose, even in the face of disability. So I was interested in disorders. And then I was actually at church one day. My husband's a church musician. So we were there, and the bell ringing choir, the woman who directed it for many years, was retiring because she had Parkinson's. And as you can imagine, conducting with Parkinson's, when it presents with a tremor, becomes impossible. So this little lady happened to be sitting in the pew in front of me. I didn't know any of that. I was just at church. But she was very emotional about it all. And she was shaking so hard that the entire pew, her pew, was rocking. And the older guy beside her, who's obviously her dad, was totally embarrassed. So he's kind of like putting his hands on her, trying to make her stop, and she was just shaking more. And then we hit that part in the service where the minister says, you know, can you turn around and exchange your peace be with yous, which I usually hate because I'm so self-conscious. But in this time, I didn't even really think. I just kind of reached forward and said, would you mind if I put my hand on you, at the same time as she was turning? And when I put my hands on her arm and put them together and just opened, in the words of the Alexander technique, her tremor stopped. And all of us were shocked. And, you know, so then we kind of stood like that and went back, and she shook then afterwards, but in a much smaller way. And after the service, her dad came and said, how did you do that? You know, kind of like it was a voodoo thing. And I have to say that this I find it is miraculous that you can put your hands on a tremor and stop it. It's almost like taking that excess energy, and it's not a voodoo thing. It's a caloric thing. You know, that's sort of how I describe Parkinson's to people in a non-scientific ways. It's like all that energy which leads to movement in a Parkinson's person is damned. So it spills all over the place in different kind of ways, becoming too much effort somewhere, or this shaking. So anyhow, Allison got interested, and we started to work. And, you know, fast forward, we just worked normally, and I continued to do my work in theater, when suddenly we realized we'd been working for about 8 years. And Allison's ability to move was tested annually by the local movement disorder clinic. And we realized, when we looked at her charts, that her scores had improved past the point she was at before she was diagnosed. Wow. So she was 8 years into a Parkinson's diagnosis, but her movement was better. Now, I should say her ability to move was better, because it's not that the disease didn't progress. It progressed. She had to think about it. When she doesn't think, she curls right over and is this little shaking thing. But it's phenomenal to look over to her. And for me, I just usually point up, and she'll just uncurl and open up. And then, as in her words, walks like a real live person. So that's huge. And that's what led us to go to the World Parkinson's Congress for the first time and take that data with us in a little case study, which was fairly intimidating for the actor to go to the science and medical conference and present. I got my friend, who is an engineer, to help me understand how you put together a scientific poster. That was in 2013. I've come a long way since then.
That's incredible. Yeah, you wrote a book. You've come a long
Well,
way.
eventually I wrote a book.
Yeah, well, that's incredible. But I think it's great. I think that you're very charismatic. So I think that, the Alexander technique, your acting training, certainly combined with the Alexander technique, it makes you a wonderful candidate to be able to lead this study and write this book, because I think that you have an energy about you that definitely instills a sense of hope in these people from your stories, from what I've read in the book. I mean, it's really, truly remarkable. It almost seems like magic. Like if you don't know the Alexander technique, you don't know how it works, then you hear this, like it happened in church, it's like this miracle kind of, but it does have that kind of like what you said, you opened up. You were in a situation where she was willing to open up to, and there you go. It's amazing. So could you give me some examples, or share with our viewers and listeners some examples of some of the challenges that people with Parkinson's experience and how you've been able to help them? We have the story of Allison, but more specifically when you're working with them one-on-one.
Right. And again, when I wrote this book, it was like, I wrote it to be like a car manual. That's how I wanted it to be, so that whether it was a teacher or a caregiver or a student / patient, that if they were having problems with their feet, they could flip through and look at, first of all, how things are put together. And then secondly, how you're designed to move and how you're designed to function. So really the way that I approach this work is, if a student comes, we work on what they can't do. What's hard, what's tricky. If they're newly diagnosed, which is wonderful to start to work then we just work on preserving function. But things happen with Parkinson's that are, it is important to do the kind of, thank you for inviting me on this podcast, because the world doesn't know really what it's like. People with Parkinson's are arrested for being stoned, because sometimes they will freeze, and again, freezing is a phenomena that can't quite be explained, even to this day. It's just suddenly they'll just hit, it's like an air pocket in function, and they just are stuck. And it's like everyone's worst nightmare, I think, to imagine being unable to lift your foot. And time sometimes passes at a different speed for them, so that also can make people on the outside think they're stupid, or, these are just living, breathing human beings with challenges. So it kind of divides roughly into the people who present largely with tremor, like Allison, and the people who present largely with rigidity, like Phil. And then there's a host of other disorders that can happen, including internal disorders. But really, when we're working with people, the first thing that I do is help them understand where they're designed to bend, because there is data out there, and neuroscientists in the world who are looking at the fact that when you present with kyphosis and you have Parkinson's, so kyphosis would be, this kind of hunched upper back, which sometimes can be, it's interesting. We'll just stick with kyphosis for now. It can come from other disorders too. It can sometimes be something called a dystonia or a camptocormia. It just means that the reason why they're stooped is different. But when they're like that, studies have shown that if a patient presents with kyphosis, they will develop dementia. It's just a knock-on kind of progression, and that Parkinson's may actually be connected to damage deeper down out of the brainstem and into the top of the spine. So it's not rocket science. The first thing that I work on is helping get people straightened up, which I think every physiotherapist also does. It's just that our work gives us different tools to look at organization of the body. And so softening those rigid muscles and teaching them where their head is, that's a huge thing to start to work on, and to help their caregivers understand that too, because it's been my observation that once people progress to a certain stage, like where Phil was in Parkinson's, there's nothing to help them anymore. They can't go to exercise classes because they lift their arms and they fall over backwards. You know, it's that bad. So my hope is that with the Alexander technique, we can make it much more common for people to have a way to learn just to move, so what I would call function externally, so that they're bending at the hip joint and they're not compressing their back, and that their knees and that their ankles and their feet flex. Then when they develop to that point, then they're able to start to embrace exercise programs and other things. And I mean, when Phil and Blanche were working, in the miracle that became Phil's change, they were exercising 5 to 7 hours a day, but it was all Alexander based, especially in the beginning. And I'm sorry, I know I get carried away in passion. Did I even begin to answer the question?
Yes, you did. Well, sure. I mean, it's, you know, how you work with them. I mean, this is part of how you work with them. It's the communication, the building the trust, learning to do the exercise, which I hope that we'll get to at the end, and so we can discuss some of the things that were more practical. But I think another thing that's worth mentioning is that I think in our own community and the Alexander technique, some teachers are apprehensive, a bit nervous about working with people with Parkinson's. They might be afraid of hurting them. They might not be familiar. And that's why I think your book is also so important. It lets you ease into and understand. You basically work with them the way you would work with any student, but there are things that are specific that can really help if you put a bit more focus on certain exercises or types of movement. They can really help this group specifically. So I think that there definitely has to be more awareness generated in our community, and to kind of list this also on our websites, that we also work with people with PD, and so that a lot of people seek teachers for this reason. They've heard about the studies. I know Monica Gross has also done some studies, and she's part of the Parkinson's Foundation. So there is conversation about that out there, you know, also for them. And so they're drawn to teachers. So I think we have to really educate ourselves more in our community. And I think you're doing a great job. I really, truly, the teachers listening to this, I think that your book is a must-have. I've enjoyed it so much. It's such an easy read. It's beautifully written. It's so clear and straightforward. The stories are, you know, I was like in tears. They're very emotional, but they're the kind of the trials and triumph kind of story that I think that's the message, and that's what gives hope. And if this is what's in your writing and this is who you are as a person, then how can people not experience that in a lesson with you? And that's what I think any teacher would want to be able to instill in their students, is this hope.
Well, and that's where I'm at after. So let's see, I must have had my first lesson with Alice in about 2008. So that puts me kind of 12 years into working with Parkinson's. And actually the Poise Project, Monica Gross phoned me. And we, you know, I was in the initial conversations and the initial establishment of the Poise Project, which has kind of become more American based from a funding point of view, which is totally fair enough. So I continue to just, well, as part of actually, the book came out of those discussions with Monica and with brilliant Roselle Cohen, who's a scientist.
She's brilliant, I know.
An Alexander technique teacher who was kind enough to vet my book as we went along. But it all began when Monica and Roselle and I were writing a application for Michael J. Fox Foundation grant. Now, we didn't get the grant, but I learned a lot about the process of grant writing in that time. And one of the things that Roselle said is, really, in order to test the efficacy of the technique, we need a protocol. Physiotherapists have a protocol. Occupational therapists have a protocol. Even yoga instructors or whatever, you know, there's parameters and set out. So that is where the book Living Daily began, was just to kind of give a reference guide. And I love the idea of being able to support teachers at any stage who are interested in working with Parkinson's, like for myself to be there as a resource for them. Not that any Alexander teacher can put their hands on Parkinson's and make a change, I think. I've just struggled with this for decades, and I've worked with hundreds of people now, and I've been privileged to work with doctors and neurologists, and learned along the way. So obviously I have a long way to go in my understanding, but if I can shorten any Alexander teacher's pathway, that's what I would love to see happening.
Absolutely. Absolutely. And I think also your book would be great for students too. So even the students that maybe are afraid of starting lessons or unsure, just to have this book. I mean, I'm just so grateful for this book, because now I know what I can, kind of suggest for students that have questions, especially since I'm not teaching in person right now. And I've had people with PD reach out to me. And so now I have something, a resource that I can give them in print. And so that's really exciting for me as a teacher to be able to do that. I wanted to also talk a little bit more about the book. Two questions. First, why the Alexander technique? Why do you think that the Alexander technique specifically is working and helping people with Parkinson's?
Because the Alexander technique is unique in that we look at how someone does something. So it's not that, I mean, everyone has the right intention and idea, and many modalities and many practices can be helpful, but I really feel like Alexander technique is foundational work. So it helps a student understand how they're put together and what the problem is, as opposed to just kind of blindly going off and being told, this is how you walk and this is the height you hold your cane at. And so, for example, walking. And walking for a normal person is different than walking for someone with PD, because they have problems picking up their legs and initiating movement. So a common way of approaching that is to teach them to kick out with their feet. The problem is this illness is about creating rigidity through all the joints. So if someone kicks out with their foot and they're unstable, they're just going to go right over backwards. I've watched it happen. I just think that Alexander technique is foundational. It's not that what anyone else does is wrong. Is we can just get so much more efficacy if we're really looking at, okay, so you want them to be able to walk forward. So what's the best efficacy then in what are we asking them to do physically with their bodies? And if they just pick up one foot to kick it and are balancing on the other foot, that's probably innately dangerous. It's like boxing, boxing helps, dancing helps, because they're fluid movements that ask for a lot of range of motion. Which is exactly what people with Parkinson's need. But if they've progressed to the point that they can't do that anymore, like I said, then literally people will pick up their arms and fall over backwards, or they'll pick up their arms and have tremendous pain in their back. So when I start working with someone with Parkinson's, I say, whoa, slow down. I don't care if you walk all the way across the room or not. I'd rather you take 2 balanced steps and really look at function. I just think that is what our skill set is as Alexander technique teachers. We are not scientists and we're not doctors, but we're functional movement experts. And that's what we can bring to the table of the collective work, which is dealing with Parkinson's, because medication does work. It just, the disease is bigger than it. So it's going to grow. And same with Alexander technique. I suppose we may get to the point that people will outgrow being able to apply the principles, but I haven't hit that yet with anyone. Yeah. So
right.
I have had students die, but they've died of different causes, and with some dignity. I had one guy die who hadn't been able to hardly walk. And his last 2 years when we were working, he was playing tennis 3 times a week.
Wow. That's
died of
amazing.
He died of a heart attack, which was just so irritating. But he had a terrible heart. I mean, he had a loving heart, but his ticker wasn't working very well. But yeah, it was amazing to just die with dignity, and with choice.
Yeah, it's just so. It's just emotional when you think about this, and you've just really gotten inside of this. I think it's amazing that as a fellow colleague, Alexander technique, your work that you've done is just so important, and you're in it. You really understand it, because I think for many people they're apprehensive, like myself. I'm afraid of hurting somebody. I wouldn't want to do something the wrong way, and you went in it unafraid, and you've made such a change in these people's lives, and you're inspiring me to be braver and to also do this. And I want to be able to help my students too.
I wasn't unafraid. I was terrified, but I just did it anyhow, and that's really the thing, is just when you can be an agent for hope, how can you not go forward? And I, in the very early days, I had someone fall. But we knew that was a possibility, and we discussed it. And I said, I'm going to ask you to move. And if you're going to move, there's a possibility that you might fall. And he had this great class. We were doing so well. And then I stupidly just turned my back for a minute to get something right at the end. And he fell and I went, shit. And he went, shit. And then he said, don't tell whatever his wife's name was. Don't tell her. He said, because it was so good. Yeah. And I mean, that's a thing. It is. And when I first started teaching with people with chronic illness, I would be exhausted. So if I normally teach 10 or 12 students in a day, if I had 3 people with MS or Parkinson's or whatever, I was drained. And that has changed. I've gotten better at, again, as Alexander teachers, we have to live what we're asking our students to ask. I'm getting better at being able to stay in my own skin and stay open as I'm working, not get so sucked into the story.
Right. That's it. The getting sucked, that's the key, because then you kind of lose your Alexander technique hat. And then, and that's kind of leading me into my next question is habits. Anyone that has studied the Alexander technique or has read about it is familiar with the word habits and changing habits. And so what are some habits that you've been able to help people with PD change through your work?
That's interesting, because when I first work with people who have Parkinson's or any movement disorders for that matter, I do talk to them about how, how would you have been like 20 years ago? How would you have sat 20 years ago? How did you move when you were little? And it's just interesting, because those habits that we all have as human beings who live in a world that's out of balance, out of sync, spins too fast. We spin too fast. Of course, we all have habits of tension. And I love that. And I love it when we kind of put our hands on, Joe's habit that he's done because he worked in an office for 40 years. And so he has a stoop, because I can say, Joe, I know we can get rid of that habit. The Parkinson's is different. So I like to call it Parkinson's beyond habits. And maybe that's where our growth as Alexander technique teachers, where we need a little bit of support to trust that it's a little bit bigger, because there's a physiological, neurological reason for some of the things that are happening. But just changing everything, changing their gait, literally a lesson. You might find me lying on the floor or crawling on the floor with someone, literally putting my hand on their ankle, lifting their heel as I push their foot down. We swing that leg through and I reach over to the other one and I'm shimming along, and we do that kind of thing then there's someone else in the room to spot. But it's changing the habits of the person, as well as changing the habits that comes from Parkinson's, and starting to learn to identify those is it's essential, because without understanding how you're taken off balance for so many valid but not accurate reasons, if that makes sense, that's kind of where we're at with habits, is you have to understand what it means to really stand with your weight over your whole foot if you're going to be able to stand securely. You can be 60 years old without habits, without Parkinson's, and stand poorly and have a bad back. But if you have Parkinson's and you stand poorly, it's just going to accelerate the progression of your illness. So, but again, like I said, that's my favorite thing. It's like, we can get rid of those habits. That's what we do. But it's just interesting how many of the Parkinson's symptoms dissipate. They don't go away. They dissipate. Although I would argue that there are some, like the cramping and the rigidity, when we work on the habitual ways of, standing with your weight back or off balance or whatever, learning to change that and bring weight forward so that you're in a lengthened state more of the time, it just undoes so much of the rigidity, so much of the cramping. It is almost miraculous.
Yeah.
In those cases.
It's almost like they've had to become more mindful because of PD. And so that mindfulness then can be applied to so many other things that might make, habits that take someone else, like not stooping in their chair, 50 years, but somebody with PD, they just can't. In order for them to get to where that's just something, and that habit then gets eliminated maybe quicker even as a result, in order to get to.
I think you put your finger on it. Absolutely. Because they have to, they can't move without thinking otherwise. And so, You know, you don't work for 12 years with someone putting your hands on the devil that they wrestle every day without developing a closeness, you know. And so not all of my students, but I certainly have affection, I think, for everyone that I work with you can't not have admiration and respect for people who just deal with this every day. But I have a friend who's very similar to my age, who was early onset Parkinson's, and he hates it that he has to do Alexander technique. He hates it. And I'll say to him sometimes, okay, well, let's just kick something. I'll help you. Let's do it, you know? And he hates that he has to think every step of the way. And I hate it that he does too. But what's the option? Right. And so we change. And so he chooses, and so on we go. But it's not always easy.
No, but
it's not.
But he has this tool now, and that, you know, that's something. He
has
a tool
and it's a miracle. Yeah. So, and it's also interesting that things that just change. And when I met, you know, this particular person who is comfortable, by the way, I should say that all of the students who are featured in my book, and there's, I think, about 20 of them, I've been granted full dispensation to use them and to talk about them and to help others learn. But when I met this particular man, his cramping was so bad that he'd fall out of bed. Like literally his muscles would tighten so much that it would flip him out of bed at night. And his wife would have to beat him with she had an Irish shillelagh. She'd beat on the muscles of his calf to get them to let go.
Wow.
Yeah. So thinking through one step at a time, sometimes you just have to be reminded, yes, that's terrible, but he doesn't cramp anymore. I mean, in fact, he said, and I mentioned it in the book, that he can, if he's paying attention, he can feel a cramp starting, and he can actually, I guess you could call that directing in Alexander terms, think his way through it, and it won't happen. So, you know, that's enormous. That's power.
Absolutely.
That's power.
It gives them something that they didn't have before. I mean, before this connection was made with AT and PD, you know, there wasn't anything of the sort, just medication. So this is why the Parkinson's Foundation is showing interest in the Alexander technique, because of what they're seeing, these changes, and the help that this is giving, and the help and hope that the AT is giving Parkinson's. So I wanted to ask you a few more things. You mentioned in your book that the Alexander technique shows you what you think you are doing, and what you are actually doing may not be the same. Could you explain this in relation to space, and how that would apply not only to someone with Parkinson's, but to other people as well?
I can. I'm going to remind you that I'm not a scientist. So apologies to the neurologists who might be listening to this. However, in my limited understanding, the interesting thing about the discoveries of Alexander, who is, you know, we're 165 years or something out from when Alexander was born and working. So that's huge. And things have evolved. Our understandings have evolved. And it's almost like in some levels, we're starting to have vocabulary to explain the principles that Alexander discovered. So Alexander talks about something called faulty sensory perception, which now neurology is showing us is not exactly an accurate way of describing what happens. It's not that your perception is faulty in your brain. It's that all of us, with or without disease, experience kind of where we are in the work in a bottoms up kind of way. So sensation comes from your nerve endings that are in all your joints. And as you move, so if you imagine a baby flailing around, that's how they learn sort of where they are oriented in space. And then as we age and we change in the ways that we move, we generally move less. And especially those of us who are very engaged with technology, we move less and less and less. So we don't get that same sensory feedback that gives us a big, wide sense of ourselves in space. Because sensory information is sort of a top down or a bottom up kind of information. Whereas the part of your brain that that catches and shapes that sensory feedback that comes in from the nerves is called perception, and our ability to perceive. So perception just works with the information it's getting from sensation. So if you stand, you know, like a model does all the time with your weight back and your hips forward, and that's what you do most of the time, that's the information and the feedback that you're getting. That's what your brain says, okay, that's standing. That's how it is. So then people think that that's standing up straight. And then they have an Alexander lesson, and we move them so that they're actually organized in such a way that their whole weight is kind of like a column over their feet, so that there's the least amount of gravitational pull. In fact, gravity is working to keep them upright. And they're like, whoa, that doesn't make sense. That I'm crooked. I must be falling forward. Right. And right. So that's present in all people, bigger and smaller. And I think it's one of the first lessons you have to have in your Alexander lessons to start to understand. And that's also why we use a lot of mirrors, so that people can see. And it's always gobsmacking to look over and see where you are when you're absolutely convinced that you are, you know, a monkey with your bum sticking out and your arms hanging, and actually you're just standing there in this beautiful straight line. So that's the normal person. And then you get Parkinson's, which is messing with perception and cutting off sensation. So if you ask someone with Parkinson's to lift their arm, they'll go, and you'll say, no, lift it high. And they don't perceive from their sensory feedback where they actually are. And that is why I have found that my job sometimes becomes almost marriage counseling in the early days with caregivers, because the caregiver is so frustrated because they're saying, stand up straight or do this. Person with Parkinson's is convinced that that's what they're doing, and they're not. So it really is this phenomena that we somewhat erroneously call faulty sensory perception in the Alexander world, in just in an enormous kind of way. So that's a big thing to change. And I sometimes say this to anyone, you know, so if you have Parkinson's, or if you have bad posture, if you have Parkinson's, you might think that you've straightened up, but you just don't know because you can't get the feedback. But what's interesting is you might not be able to tell where you are in space here, but you can tell if you're actually touching the back of your chair. So that's a beginning of a learning, is to ask someone to sit so they actually can feel the chair, which is interestingly different. It's like a different neurological pathway. So they can perceive where the back of the chair is, and therefore that means they're sitting straight. And so then, you know, they fall back into their Parkinson's habit. And then, which is it a habit, is a symptom? I think it's a tangle of both. Mm-hmm. So rather than their partner saying, sit up straight, something that can be useful is to just say, can you find the back of the chair with your whole back? You know, can you feel your shoulders there? And that's,
I mean, that example that you gave about the chair is incredible, because it's like, it seems like a person with PD is receptive to feedback from an external object like a chair. So while the internal habit, they might not be as aware, but that feedback from a chair, you know, is something they can respond, which then can help them with their body habit as well.
Yes. Now, the other thing to remember is that it depends on the age of the habit that probably is pre-Parkinson's, as well as the severity of the symptom. Because something that I found when I was newly working with this is, you know, I'd be working with someone whose head was way far forward. And so my thought was, okay, I'm going to lie him down, and then I'm just going to take his head all the way back. You know, no, the body just doesn't change that fast. And it's terrifying for the person on the inside, because remember that faulty sensory perception, right? So he's here and he thinks he's straight. So if you move him 18 or 20 inches, he's terrified. Even weirdly, when they're lying down on the table, they're terrified they're going to fall as that straightens out. And then you start to realize the tangle of how everything fits together, you know. And then I can tell you, I worked with another man who had Parkinson's and had a terrible stoop, terrible. His wife couldn't handle it at all. Because especially, and this is tricky because I put my hands on him and he was actually able to straighten up beautifully. As soon as I took my hands off, whoosh, right back. So I can't do it. His upper back would have been parallel with the ground. And his wife actually started to sob and left. And I said, so can you think about maybe just opening back up and so that you can actually see out into the room? And he said, I would, but I can't. And I asked him why, and he said, well, it's the spiders. And I said, what spiders? And he said, well, the spiders up there, all along the edge of the roof. Can't you see them? The spiders. And then he went back down. Hallucinations are a common side effect of the medications.
Wow.
It's really like untying fishing net, that's all tangled up in a ball, and you just do it one knot at a time. And then sometimes you'll have untied the knot, but you let go and everything just slides back into the memory of those kinks, and then you smooth them back out again. But the astonishing thing is that regular hands-on feedback with a willing participant, and they have to be willing, because all people who come to Alexander lessons are students, and students have to participate in the educational process, so they have to be willing. But if they're willing to participate, the change is extraordinary. There's just something about that outside guidance. It's like, I trained with an anatomist who said we're designed to be easy. We haven't evolved as the human species, top of the food chain, to be hard. So when you can show a system, which is a person, where they're meant to be, there's something in them that resonates back to that ease.
That's wonderful. No, it is. I think the body wants to live. The body is designed to live. We are, bipedals. We are supposed to be up. That's how we've evolved. And, when you were speaking, it made me think about how change and progress are so relative. It's, as a caretaker, they might want someone to stand up straight because in their body, that's a goal. But for somebody else with Parkinson's, just moving a bit more up, that's a huge thing. I think that with that lens, to kind of think about progress, like what we see as progress, what they experience as progress, are not always going to be the same thing. It's not going to look like, but it might be so much more meaningful to them.
Well, and I think that that's a really valid point too, that we have to hold as Alexander teachers. And I think we have to go in as teachers totally prepared to make mistakes and not know, and just keep throwing yourself at that brick wall, which is Parkinson's. And I'm very open and honest with my students when I don't know. I'll say, well, I'm not sure what's going on here, but let's try this. And sometimes it's like, okay, wrong direction. No, forget that. And we'll try something else. Rarely, I can say that now, more after doing this for a long time. But, mistakes were copious in the beginning. Like I said, I had a guy fall over on me. That could have been a fail. I could have just walked away then, but he didn't want me to. He wanted to take the risk.
Could you reiterate again, in the big scheme of things, not just for PD, what does that mean? What does that mean it's not how you do? Could you give me an example of that?
Well, it's to me, I think, if someone has Parkinson's disease, for example, and they bend forward, they're doing an exercise class, and they bend forward 5 times, and they fold their spine to touch, because they can't get their head back. And then they touch the ground 5 times. I think that actually is what I call practicing the disease. So I would rather them do it once and be able to start to get a sense, of moving much deeper and out of the hip, which with Phil, the truck driver who was 6 feet tall, 6'6" and super strong. He couldn't bend there. That's why exercise wasn't efficacious. There was no efficacy in exercising for him, because he wasn't able to move in the way that they were asking, and just practicing those Parkinson's contracting did not help. So in our first lessons, Phil, part of it was just getting him to sit, because he couldn't sit without falling, because he couldn't bend in the middle. Can you imagine the terror and the anxiety that comes with this illness? And anxiety is a huge benchmark in Parkinson's, because he couldn't bend to sit. So he sort of fell like a log into the chair, and then somehow it caught him. And then getting out was the same kind of nightmare. So in our first classes, I actually would stand, Blanche would be up behind him. I'd hold his arms, and I'd stand on one foot and put my other foot in his hip joint and push him backwards with my foot as I was leaning back to get him to bend, because my arms weren't strong enough to get that kind of backward movement, and his body needed to be shown how to do that. And we did that for 2 years, variations of that. And Phil has changed tremendously now. He lost his driver's license early on when I first met him, and he's gotten it back, and he drives.
That's wonderful.
He teaches boxing at the gym. Blanche has gone back to work. If she's busy, he just gets up. He dresses himself. This is a guy, they had to take changes of clothes with him because he often couldn't make it to the bathroom because he couldn't move. He couldn't get up. But so it's how you go about asking him to move. And I think that's the strength of this work, that if we could just kind of lay a foundational line for people to understand how to work and then pass the baton on to the physiotherapists who are the experts in exercise. I'm not an expert in exercise. I developed a bunch of little movements that I encourage people to practice who have Parkinson's, which is sort of anti-Alexander in a way, because it is a doing. Mm-hmm. But it's like, this is bigger than habits. This is beyond habits. So we need to just be bigger in what we ask someone to do. So they have to practice bending like that as much as they can. So for example, it's terrifying for people with Parkinson's to displace backwards because they fall backwards so easily. But of course, it's a very different thing to have your bottom hinge backwards mm-hmm. than to come backwards from your heels right. where you're going to go right. over. So, and they can't perceive where they are in space. So I might have them stand in a doorway and hang on to one side of the frame, and then just slowly bend their knees and push their bum back until they hit the other side of the door frame. Again, that's something that they can do, that they can feel, if they're able to. And people who are able-bodied and come to the work early with Parkinson's, then that's just something that we keep working on and getting their range bigger and bigger. And yeah, it's helpful. It's definitely helpful.
You touched on something that was really interesting to me in the book were the exercises. Could you just share some of your clients' favorite exercises, or the exercises that you find that you've put in your book that are most effective for people with PD, and also those who the caretakers that work with PD?
Well, I think, again, it always comes back to principles, right? To Alexander principles. So it's not about the exercise. It's about what you're looking to achieve in this person whose organization is out of kilter, So to me, the biggest thing that is missing in Parkinson's is your feet aren't solid underneath you. And it's just fascinating to watch. So people with Parkinson's, their feet come off the floor, like enormously. So often you'll see that their feet will dance when they're sitting. There's never a solid connection to the ground. Or they'll be standing and their toes will just lift. And these are involuntary things that they have to consciously become aware of and then choose to mitigate. And so the feet come off, the head goes down, and you're just slowly compressed. So any way, any exercise, any shape that you can practice to start getting that turned around, so that there's I always say, think of being on a trampoline. The point is you want to straighten out and go up and be as tall as you can. But on a trampoline, if you want to jump high, you don't start by jumping high. You push down so that you can go high. So it's that beautiful balance of up and down. And it's like a heartbeat or a breath, that there's this into the floor and away. I've got a student who, when she walks, thinks of push, push, push with every step, because she needs that push down in order to come up and to keep her balance. So from an exercise point of view, to me, it's fascinating and it's also interesting, the resistance to do this. When I can get students who have Parkinson's to sit with their knees higher than their hip. So they're sitting on a chair, say a normal chair, with a stool underneath their feet. And I know you wrote a podcast about how terrible chairs are, and I so concur. Chairs are too big, and they lead to a lot of damage and a lot of habits, and they're impossible for someone with Parkinson's to get out of, because they can't get that spring, even if they're sitting with their legs parallel to the floor. I would argue that we actually shouldn't be parallel to the floor. We should be, when we're sitting, essentially supporting a squat so that the knees are higher.
Yeah.
And then that also, even if you do this, if you happen to be listening to this, if you just experiment with grabbing some textbooks or a stool or something, putting them under your feet, you'll feel that as soon as you do that, your back straightens. It's again, those opposing forces that we want to turn around so that you've got more pressure in your feet and more length in your back. And that, when Phil began to do that, and it's quite by accident that we found the efficacy of that. I was at his house and I saw him sitting in his recliner. The curse of the recliner.
Yeah.
And of course he was just stooped and crunched right over. We were doing a news interview. That's why I was at his house. I would never have seen this. And I'm like, Philly, you can't sit like that. Like, I hate this. And so I just grabbed something, my backpack or something, and put it under his feet. And lo and behold, his back straightened out. And I'm talking to the interviewer, and all of a sudden Phil goes, geez. And he's really quiet. So for him to do that was amazing. We all looked, and he had to take his feet down because the stretch was so enormous for him, just sitting like that.
Wow. After
we did that, the dial went up, and suddenly his cognition changed. I mean, this is now anecdotal from a scientific point of view. I can only tell you what I observed, and his doctors and his wife, is that suddenly he started talking more and he was more present, and it's miraculous. And it really came from that time when he started to straighten out his back, because then being Phil and Blanche made him do it for hours every day, you know, like, and his back straightened, and as his spine straightened. That's why I think getting the head up and over the back is so important. It just makes a big difference. So that's my number one prayer. But it is interesting because it feels so uncomfortable. There's a resistance to doing it, which is funny, and also why, again, you sort of develop this relationship with your students and your patients who are like, okay, I know you hate this, but you have to do this. And it's nice now that I've taught more and more people for a consecutive amount of time, and we can see that there's a pattern to the change. But I also want to be clear, you know, not everyone who comes through the door with PD leaves with a miracle.
Yeah.
But there's a lot of mini miracles that happen along the way. They have to want to do it, and they have to be able to do it. We have to remember that this is a neurological disorder. And apathy can be a symptom, a clinical symptom of Parkinson's, which means they actually become apathetic in a way that has nothing to do with conscious choice. They just, maybe it's nature's way of helping them cope with a degenerative illness. Mm-hmm. It just turns off. And that's hard. That's hard for the caregiver.
Yeah.
But, and I never, ever fault anyone for not being able to take this on. But if you can, it can be tremendous. Yeah.
Thank you, Candace. This has been tremendous. This has been so eye-opening. Another thing I just wanted to mention, in your book, you provide so many pictures, and that makes it also more clear, like the picture also of the stool with sitting. I think it's wonderful. I think that really anyone who works at a desk during the day or sits behind a desk should have a stool, as you mentioned, or stacks some books. It's something that I started doing with the books too a while ago, because it makes such a difference if you're spending a lot of time, if you're writing or doing podcasts or whatever it is that you're doing now with lockdown.
Under my feet right now.
There you go. You know, and so I think that that's you know, another valuable part of the book is that you have the images to really help kind of explain, and they're beautiful, beautiful images that you have. It's a wonderful, wonderful book. I'm so grateful to you for doing this podcast with me and for sharing your brilliance and your vibrance, and just, you are lovely. And I wanted to ask you, is there anything that you would like to add before we finish up today?
There are changes there that we don't know exactly, but when we can restore external function on the outside, it changes something neurologically, and we need research. So that's where we're at.
Yes.
We need to mobilize as a community.
Yes.
And recognize that anything we can do is good. It's better. It's different, and help be part of the team of people who care for people with Parkinson's. And I think we can change the world.
I think so, and you are paving the way. So thank you so much, Candace. Thank you for joining us today. Thank you for sharing your story with us and your book.
Thank you. Thank you for all your work, Tami,
My
that
pleasure.
you do with this podcast.
Thank you.